And then?
And then Jaakko Toumilehto from Finland.
Yes.
Yes. Jaakko Toumilehto from Finland, MD, MA, PhD, FRCP, Professor Emeritus, Public Health, University of Helsinki, Finland, visiting senior scientist, Finnish Institute for Health and Welfare, Helsinki, Finland, and visiting professor, National Public Health Institute, Madrid, Spain. And his subject is cardiovascular risk factor management and prognosis in patient with dysglycemia. I'm requesting Dr. Jaakko Toumilehto.
So thank you very much for the introduction, and thanks for Dr. Banshi for the invitation to join this meeting once again. I have enjoyed the face-to-face meetings also. I have enjoyed a lot to be in India, but now from Finland I will present my lecture here. Now I need to find this one. No? Okay. So it's not, just a second, not in the beginning. There we go. So my lecture is about the cardiovascular risk management in people with dysglycemia. Here is my conflict of interest. Now, we know that people with diabetes have an elevated risk of cardiovascular disease, whether it's a cardiac or cerebrovascular or other vascular, that is a peripheral vascular disease. So very clearly, diabetes is an important contributor to cardiovascular burden in a global sense. Now, the question then is, what can we do to reduce this burden? And what I'm going to present is quite a lot of information generated by the European Society of Cardiology and the European Association for the Study of Diabetes. And this is an update. I was working in the 2009 and 2013 recommendations, and this is the latest one, which I was not part, but very much involved in the discussions. Now, this analysis of cardiovascular risk in diabetic individuals in the 3 different categories: very high risk, if there is already some target organ damage, or 3 or more major risk factors, or type 1 diabetes over 20 years duration. And a high risk is people with diabetes duration over 10 years without target organ damage. And a moderate risk is typically a young person with type 1 diabetes or type 2 diabetes without any other risk factors. Now, recommendations in this document are based on a classification of ranking the evidence, and the class 1 and class 2 are those where the evidence is sufficient to make a clear recommendation. Now, the microalbuminuria should be measured in people with diabetes. ECG should be also taken in people with diabetes, especially if there is hypertension or suspected cardiovascular disease. And also the carotid or femoral plaque burden with the ultrasonography should be considered in asymptomatic patients with diabetes. And when it comes to advice for lifestyle, smoking cessation is recommended for all people with diabetes and pre-diabetes. And actually, I would point out that these recommendations, they very much also go to pre-diabetes, not only to diabetes. The lifestyle intervention is recommended to prevent conversion from pre-diabetes to type 2 diabetes, which is known to be very effective, and reduce calorie intake if people are obese. Now, when it comes to physical activity, the usual recommendation is 150 minutes a week at least for prevention and control of diabetes. And then the evidence is accumulating that the so-called Mediterranean diet, which is rich in polyunsaturated and monounsaturated fats, should be considered to reduce cardiovascular events. And the multivitamin supplementation is not recommended. There is no evidence that the vitamin supplementation reduces the risk of diabetes or risk of cardiovascular events in people with diabetes. When it comes to the targets, the main thing is hemoglobin A1C less than 7%. This is to decrease microvascular complications, which is well known from several studies. But we know now that A1C targets should be individualized according to duration, comorbidities, and age, so that it may be higher in some individuals, especially with the comorbidities. An important point is to try to avoid hypoglycemia, because it's known from glycemia is one of the factors resulting in cardiovascular disease in diabetic individuals. And then the self-monitoring of blood glucose or continuous glucose monitoring should be considered to facilitate the optimal glycemic control. And also, when we think of macrovascular complications, again, the A1C is recommended. When it comes to treatment with antidiabetic and antihypertensive drugs is recommended if the blood pressure is over 140/90, and then the goal is to reduce systolic pressure to less than 130 if tolerated, but not less than 120. There is no evidence that less than 120 would be beneficial. Actually, it may be harmful. And in the older people, a little bit more flexible goal of systolic pressure should be considered. And again, diastolic target should be 80 or less, but not below 70. And for cerebrovascular event, especially important is to consider systolic pressure less than 130. Now, lifestyle changes for treatment of hypertension are important. It's convincing evidence we have today that the physical activity, reducing overweight, restrict alcohol intake, restrict sodium intake, and to increase fruits and vegetables and low-fat dairy products are useful to lower blood pressure. And then when it comes to treatment choices, the RAS blocker is recommended in diabetes, especially if there is evidence of albuminuria or left ventricular hypertrophy. And quite often we need a RAS blocker and then calcium channel blocker, which is neutral regarding glycemia, or thiazide diuretic should be considered, although thiazide diuretic may have some unfavorable effect on glucose levels, but once people already have a diabetes, the effect is much smaller. Now, in people with pre-diabetes, also RAS blockers should be preferred to beta blockers and diuretics, because these latter drugs may increase the risk of progression to diabetes. And of course, today there is a lot of discussion also the SGLT2 inhibitor that may also lower blood pressure. And home blood pressure monitoring is nowadays recommended, and also in many patients it would be useful to understand the 24-hour blood pressure patterns, especially the nighttime blood pressure, in order to adjust the antihypertensive treatment, which usually is now recommended to take late in the evening before going to bed. There is an evidence that taking antihypertensive drugs at the bedtime reduces cardiovascular events more than if you take the drug in the morning. Concerning a lipid management with the moderate risk of CVD event, the LDL cholesterol target is 2.6 millimoles, and in those with a high risk, 1.8, or at least 50% reduction in LDL. And in those with a very high risk, LDL target should be even lower, 1.6, and again, at least 50% reduction. And in individuals with type 2 diabetes, the non-HDL target, which is today very much used in the clinical practice in Europe at least, there is the goal to have a less than 2.2 millimoles in very high risk and 2.6 in a high risk patients. And statins, of course, are considered the first choice treatment for lipid lowering. And again, the administration of statins is depending on the CVD risk profile. And if LDL cholesterol target is not reached, then ezetimibe is recommended. And also with a very high risk CVD patients, and if statins are not tolerated or effective, also PCSK9 inhibitor is recommended. And again, the lifestyle intervention with the weight reduction and reducing fat intake are recommended. And also the fibrates may be considered if a patient has a very low HDL cholesterol and high triglyceride levels. And always it is important to intensify statin therapy before introducing the combination therapy. Then it comes to aspirin. It is recommended in the very high and high risk patients with diabetes, even for primary prevention. And in patients with a moderate CVD risk, primary prevention use of aspirin is not recommended. And when aspirin is used, one should consider to use proton pump inhibitors in order to prevent bleeding, GI bleeding. Now, these individual recommendations are important, but we have to remember that the combination management is the key. We have to take into account hyperglycemia, hypertension, dyslipidemia, microalbuminuria, and antiplatelet treatment at the same time in order to reduce complications. And the STENO2 study is a very good example where we have seen that the multifactorial management reduced A1C, cholesterol, blood pressure, and triglycerides, all significantly. And the target was reached best with a statin therapy for cholesterol, and also the diastolic blood pressure target with antihypertensive drugs. Whereas glycated hemoglobin to go under 6.5 was difficult to reach. Only 15% actually managed to get there. Now, these are the results regarding the microvascular complications, and you can appreciate that all nephropathy, retinopathy, neuropathy events were reduced by intensive therapy here on blue. And it was at 4 years already significant, and then there was a follow-up after 8 years, and the effect remained. And even after 13 years, when between 8 years and 13 years, no more intensified therapy was offered, but the patients were receiving whatever management they had, the effect remained. So it was very clear that there was a beneficial effect of the intensive therapy, also for mortality and cardiovascular events. After 4 years, mortality was not yet significantly different, but after 10 years, it started to appear, whereas cardiovascular events already after 4 years were significantly reduced. So very convincing evidence that the multifactorial management is working to prevent cardiovascular events in type 2 diabetes. And when it comes to these recommendations today, how to treat the very high and high risk patients with diabetes, now should be considered SGLT2 inhibitor or GLP-1 agonist in monotherapy, whereas low risk patients are using a metformin. And then there are stepwise increase in the medication, step 1, step 2, to continue like that. So the algorithm is quite clear how it is. And more about it you can find in this guideline in the European Society of Cardiology website. Thank you very much for your attention.
Very useful and practically very relevant discussion. And thank you very much, Dr. Jaakko, for joining us. So let us have a very brief question. So we have been discussing about the use of aspirin and the routine use of aspirin, and the recommendation is also to use the routine PPI. But there has been a recent recommendation to de-prescribe PPI due to the higher prevalence and the association with chronic kidney disease with proton pump inhibitors. So how can this go together?
You mean together with aspirin?
Yeah, with aspirin we are giving,
Yeah, so clearly this is an option for especially for the very high risk individuals, and naturally for the diabetic patients who already have cardiovascular disease, some sort of cardiovascular disease. So yes, this is also in the guideline is recommended to have a combination in a very high risk individuals. I didn't go to that, but yes.
You have dealt with very practically very relevant and probably a very controversial topic, the use of antihypertensives routinely in diabetes. Though we keep on discussing this, it is still remaining as a controversial and a topic of debate. So with the emergence of SGLT2 inhibitors, do you think or do you presume that the total dosages of antihypertensives will come down eventually?
Sorry, that was cut off. I didn't hear your question.
Jaakko, my question is, the SGLT2 inhibitors can also result in a subtle reduction in the blood pressure.
Mm-hmm.
So with the routine use, you have recommended routine use of SGLT2 inhibitors now in diabetes. So do you assume that the total dose of antihypertensives can get reduced with concomitant use of SGLT2 inhibitors?
Yes, I would say yes. With a full dose to try first, and then I personally would prefer to use to start using a combination therapy with a calcium channel blocker and RAS inhibitor to start with for every patient with diabetes. So that would be my personal choice. And it has been shown that especially in diabetic patients, to start with this combination is reducing cardiovascular events more than using other drugs.
Absolutely, it has got tremendous long-term benefits as well. So thank you very much, Dr. Jaakko. There are more than 8,500 doctors listening to us in the virtual platform. And a profound gratitude for joining us live.
All right. Yes, thank you. Thank you.